see the cartoon of Trump sitting at his desk with the game Operation? You know, where you have you have the tweezers where you take the bone out of the guy and you can't touch the side, and it says, "Who knew how complicated it was?" It was obviously photoshopped. It's very funny, but we'll take it more seriously. Uh, okay, that sounds good.
Giant step? How's that? There we go. Come on in a little. Stay there. Looking good. Right to the camera. Eyes are right straight ahead. One more time. Perfect. Keep looking right straight ahead. Good. One more time. Flash doesn't like me. Stay there. All right. I'll take 6. Let me check. How you gonna autograph it, Mr. Flash? Right here. Stay there, guys. Nice. There we go. Now we got it. Right here. That last one. Perfect. Right there. The only autograph I want is Hal Garland. There you go.
Well, I'll tell you, it's the Rutgers look. Got the Rutgers look, the Seton Hall look.
Wear my breakfast.
Got it all covered.
You want your medical school back?
Be a little crowded with two.
Yeah. Well, I guess you have a new one, right?
Yeah. My chair is way too high.
Oh, these are very high.
Didn't you tell them you're going to lose money?
You know, I
don't know
what I said
No, I have a
when
number. I
they
have-
announced it, they didn't. You'll be shocked to know they didn't ask me. Whenever I say that, people start rattling off. Apparently, there are 4 or 5 new medical schools.
Yeah.
I'm not going to mess around with it because I'm
Yeah.
afraid I'm going to really make it worse. That's my usual thing, right?
The AAMC has been like beating the drum that we have looming shortages.
I've asked the new dean about residencies. I said, start thinking if we got new medical school, we got to start thinking about the residencies. Yeah, got it. We're all over that.
Yeah.
Whatever that means.
I'm quieted now.
So we've been working with Seton Hall on this, I don't know if you read it, this leadership academy that we started. So the hospitals and the docs and the class this year, but it's run through Seton Hall, and it's been really great. We're doing end of life care is sort of the first.
It's always a good place to start.
Yeah, right. Start at the end, right? And it's interesting. Folks together, and the idea was to sort of develop relationships, cross-pollinate ideas.
Dialogue, right? Than like each of us doing like a okay.
So where are the
I think
Seton Hall
so.
folks from? Are they students or faculty or?
The faculty is sort of they've organized a curriculum for us, so we've used them as sort of a vendor.
From what school?
It's a really good.
You know, I'm thinking my sort of the first question will be just to the group, and we can just go down the line,
RFP we worked at.
right? So, and
spot for everything.
Yeah, that's right.
What's the Senate going to do?
I can't remember where it was.
Not law school. At least-
No, yeah, it's not the
Hope
law
it's not law school.
Yeah.
I would know.
So I just got an insulting text message from Margaret that said the panel looks like the Senate AHCA drafting panel.
Wait, make us open. Yes, thanks.
I remember speaking at a bankers convention. There were like 500 people on healthcare reform.
I think every single person in the audience was a silver-haired 60-year-old.
White man. You guys,
You got something? You got a problem with that?
yeah. Looked like an episode of Mad Men.
Well, at least my shirt has a pattern on it.
There you go.
There's diversity.
Mine does.
It's like an appellate.
Yeah, it sort of does.
We're going to reflect all the new judicial appointees too. It's 120
Something like that.
federal judges.
Good morning, everyone. We're going to start in a minute or two, so if I could ask you to just see if there's anybody outside so that we can get everybody in and we can start, because we want to move right on to this morning's program, which is, I think, certainly important, and everybody, I think, has a great interest in what these very knowledgeable gentlemen have to say today. My name is Hal Garwin, and I am the Executive Director of the Community Health Law Project. We are the organization that has presented and conducted this Law and Disability Conference for many years on behalf of the New Jersey State Bar Association and the New Jersey Bar Foundation. The foundation is the host and the sponsor of this program. They, as many of you probably know, put on numerous activities to benefit the public and to enhance the public's knowledge of the law, and the activity from moot court programs for schools to programs for the public and professionals on a variety of topics. And the Community Health Law Project is pleased and privileged every year to have their support in putting on this conference. This conference emanates from a concern that the Law Project, the organization, has to provide the public, families, consumers, and professionals about some of the important issues that are occurring in today's world related to the law and people living with disabilities. The Law Projects have been in existence about 41 years now, and we provide services around the state for individuals living with disabilities and some other special vulnerable populations. And we do that in a fashion of providing representation and advocacy through our various local offices, which are spread throughout the state, regional offices in the north and the coast, central and south, and providing legal services from the kind that you would go to for your own private attorney, ranging from living wills to evictions to specialized cases dealing with the Americans with Disabilities Act, accessibility and fair housing, the full gamut. And with that background and knowledge of handling 4,500 to 5,000 clients a year, we get a pretty good idea what some of the major issues are that are facing New Jersey and New Jersey citizens living with disabilities. And with that knowledge, we try to pull together from year to year things that would be of interest, things that would be educational, things that would be helpful to all of you and to the many families that are dealing with these issues. I think today's program really brings that to the forefront. Our opening session, these very distinguished gentlemen sitting at the table next to me, they're going to talk about something that we've been hearing about for a long time and certainly in the news today, and that's about healthcare and healthcare insurance. For all of us, for people with pre-existing conditions and for individuals living with disabilities. And each of these gentlemen are an expert in a particular area, and they will introduce themselves and talk to you about that. We've got 3 other workshops that we're going to do this afternoon. The first workshop is the Workshop 1, which is Surrogate Decision-Making and Guardianship, also an extremely important topic. And that workshop is going to be on the second floor of the Bar Center. There are stairways that walk upstairs right outside the doors and an elevator. And as you come upstairs, you'll make a right, and the room is off to the right. And there is where that workshop will take place. Workshop 2, which is affordable housing, and deals with the litigation that occurred this past year in terms of the mandate for affordable housing, and also the litigation saying that you have to make up for the past where you haven't put affordable housing, called the gap. And that is in the Gibbons Conference Room, which is in the first floor, directly behind us, off to the right. And then the third workshop, which deals with bricks and mortar and support services. And that's the whole issue that we have, where the housing for individuals with a variety of disabilities have been living in group homes or supportive housing. And you have housing, which is the bricks, and services to support them, often provided in the same fashion by the same organizations. And there's changes in what and how it is performed and provided as mandated by the federal government. And that workshop 3 will be in the Willents Auditorium, which is where you're sitting now. So later on this afternoon, you can come back in here and you can hear that. So we're going to go roughly from now, and I'll introduce the moderator of today's program in a minute. And this session will go until about 11:30. We'll have a short break, and then we'll start the workshops that I just mentioned at around 11:40. I really hope that you enjoy the programs today, that they are helpful, that they are something that will give you some time to ponder, think, and will allow for us to have some good discourse throughout the day on that. So again, I'm so pleased to see so many of you here, and I thank you for coming today, and I certainly thank the fact that it is not raining and the sky is blue. A little chilly, but when it gets to
Jinx it.
little chilly, but when it gets to be the hot summer, we'll have want the 50s of the May back. So without further ado, I want to introduce John Sarno, the Executive Director of the Employers Association of New Jersey, and I'm proud also to say a member of the Community Health Law Project's Board of Trustees.
So thank you, Harold. Thank you, Harold Garwin and the Community Health Law Project. I was just telling someone the other day, I can't imagine New Jersey without the Community Health Law Project. It's just so much part of the fabric of the state, and it does some tremendous work. It's wonderful to see you all here. Presumably you're all on the CHLP mailing list. We would love to see you at the Ann Klein dinner in October as well. So welcome. Also, thank you to the New Jersey Bar Foundation. I can't think of anything more relevant to talk about this morning. I mean, I think this is probably, for the group, our first sort of public venue since Thursday's vote, right? And I know that all of us have been, to some degree following it. Others have been following it 24/7. But for probably everybody in the group, everybody here this morning, it's something that's front and center. There's a lot to talk about. We may get into what's in that bill to the extent that we know. But there's a lot to cover, and let me just quickly introduce our panelists. I'm just going to introduce them by name and by designation. And then maybe through the discussion, we might get into what their particular area, what they're currently working on, if it comes up. To my right is Thomas Bain. He's with the Centers for Medicare and Medicaid Services, CMS. and also with the Consortium for Medicare Health Plan Operations. Now, I can tell that he's an important guy because when you see his name in the brochure, it says invited. But he's here. He's been invited, and Tom is with us, thankfully. To Tom's right is Joel Cantor, really one of the great knowledgeable talents in the state on the topic. He's professor of public policy and director at the Center of State Health Policy at Rutgers University. I think most of us, he's sort of on the must-read list. The center produces most of the relevant reports that we rely on, and certainly we have his expertise here this morning. Professor Jacoby, John Jacoby, Dorothea Dix, Professor of Health Law and Public Policy at Seton Hall Law School, another preeminent expert and thought leader, particularly where we probably are going to discuss the integration of behavioral health care. And I know that John has done a tremendous amount of work in that area. And then Ward Sanders, president of the New Jersey Association of Health Plans. I'm particularly interested, well, I'm interested in everybody's point of view, but I'm particularly interested in Ward's perspective on things because the Association of Health Plans are the insurance carriers, and obviously we'll be talking about the carrier's role in the market, the role of the market. So thank you all. So let me start with, I call this my ironic observation, and I mean, there's so much irony in the topic, and I'm not quite sure whether we have a precedent for a piece of federal legislation, a major piece of legislation that has been litigated and relitigated and reformed and re-reformed and re-reformed. I mean, it's just a remarkable story filled with twists and turns, ups and downs and ironies. So let me start with this, and then I'm just going to get a general kind of counterpoint from the group, and then lead into a further discussion. So before the ACA, as you may know, New Jersey had over 1 million residents who were uninsured. And in fact, we were one of the top states, unfortunately, right, of having the third biggest uninsured population. And related to that, we also had the third highest premiums in the individual and small group markets. That was before the ACA, so we were sort of third on the list. After the ACA, we're still third on the list. We still have the third highest uninsured rate in the country, percentage-wise, and our rates are still the third highest. So that's my starting point, and I will just get a counterpoint reaction from the group, starting with Tom, before we get into some further Q&A. So Tom, would you like to just respond to that general observation, pre and post ACA?
Okay, great. Good morning, everyone. I'm very glad to be here. So like John mentioned, I work for the Centers for Medicare and Medicaid Services, which is the lead federal agency related to the implementation of the Affordable Care Act. And I think today we're namely talking about the health insurance marketplaces and Medicaid expansion. I just want to do a quick plug before I give my remarks to what John was talking about. Is I wanted to highlight for you the CMS Office of Minority Health. This is a newly developed office, and it's focused on 4 populations: racial and ethnic groups, LGBT communities, rural communities, as well as people with disabilities. And they're developing new reports all the time, so I hope you'll check them as a resource going forward. So in terms of OE4, Open Enrollment 4, we just finished. Next year will be Open Enrollment 5. And this past year in 2017, we saw approximately 295,000 individuals enroll into the health insurance marketplace here in New Jersey. So you're probably well aware that New Jersey elected to have a federally facilitated marketplace, which means that the Centers for Medicare and Medicaid Services takes the lead on implementing that program. I just wanted to highlight two things that will be different for next year, just to keep them in your bonnet going forward. And I know my co-panelists will share different sides of this story. But the enrollment period for next year will be November 1st to December 15th. So that's much shorter than we've experienced previously. So I just want to make sure that we're aware of that going forward as we get ready for Open Enrollment 5. And then you may also be aware that people can enroll into the health insurance marketplace outside of the enrollment period. We call this a special enrollment period. And moving forward, there will be additional documentation that people will have to use to submit to the Centers for Medicare and Medicaid Services going forward to qualify for a special enrollment period. So I just wanted to flag those two things for you. But maybe I'll just pass it along before I say too much.
One can never say too much. Thanks. So, as John said, I'm Joel Cantor, direct the Center for State Health Policy at Rutgers, where we do research and analysis of the issues we are here to talk about today to the best of our ability and as impartially as possible. We like to kind of stick to the numbers. Just a couple of other observations since Tom left off with the changes in the enrollment period and related changes. Those were actions taken really for the express purpose of trying to enhance the risk pool. As folks know, premiums were quite high in the exchanges and the marketplaces, and insurers responded by increasing deductibles and copays, narrowing networks, really to keep the price point down and affordable, which led to some pretty unhappy consumers and a lot of the political momentum behind changing it. But when you look at the details of those, the changes that Tom outlined, and you, for example, look back at the Congressional Budget Office score of the last version of the American Health Care Act, the House bill that has now passed. It was slightly different back then. But they were less sanguine that those things are going to really help the risk pool. Shortening the enrollment period, for example, people who are healthier, young, healthy people, I know I'm the father of two of them, are procrastinators, and they tend to enroll in the last week. Well, if you shorten the enrollment period, you'll have fewer of them. So I'm a little bit worried about the pool this coming year. Clamping down on the special enrollment periods and raising the bar to get coverage mid-year, likewise, may not be helpful. I understand the idea. If people don't really have to enroll during the open enrollment period, they're less likely to enroll. You want to give folks an incentive to enroll and stay enrolled. It's logical, but I worry that it's going to create more problems than it solves. Beyond that, John's question was think about the New Jersey market before and after. For those who paid close attention before the 2010 law was passed, we had declining enrollment, dramatically rising premiums for full benefit standard plans in the individual market. That market was, I think, could be described as in a death spiral. In 2003, I believe, the legislature enacted something called the Basic and Essential Plan, which it's gone now, a mostly hospital-only coverage plan with a few other things added in. It waived a lot of mandated benefits, and it was great if you were young and healthy and didn't need health services until you needed them. And, I've heard lots of insurers tell me, usually off the record, that they really didn't like it either because people didn't quite realize what they were buying. So enrollment took off in that plan. So we are just wrapping up a study of what happened to people in the transition between the market before the implementation of the Affordable Care Act and after. Not surprisingly, those who were in those standard pretty rich benefit plans saw their premiums go way down, and in many cases their benefits were richer. Those in the basic and essential plan, they saw their premiums go up, but their benefits were richer. So you can't say unequivocally that they were better off or worse off, depends on what they want. If you want cheap and skinny, they're worse off. If you want not so cheap, but a real health insurance plan, they are, they may consider themselves better off, especially if they're subsidy eligible. So I mean, that's sort of our take on the transition in the market. We'll come back to the Medicaid issues, which I think are the kind of bigger, particularly for the disabled population, sort of the bigger sort of looming issue as we look forward under the American Health Care Act or whatever it becomes over time. So we'll come back to that.
All right, thank you, John.
Thank you, and I want to just say that even though the program doesn't indicate it, I was also invited. I just accepted.
Okay. So Professor Jacoby's also
Lest you think I wandered in off
very
the street
important
and
guy.
Came up here onto the dais. Okay, so I think that I would like to speak mostly about Medicaid issues, and I realize we'll come back to that. And let me just give you a little spoiler here. The reason that I will want to speak more about Medicaid is that I think that the trajectory of coverage of very vulnerable populations, poor people, people living with disabilities, has improved over the last 7 or 8 years, or at least the tools have been present to help those people. And I'm looking at, Bev Roberts and Tom and Phil and Joe Young back there, and people who work on issues of people with disabilities, I think, found in the ACA a lot of tools that were sometimes well implemented, sometimes lagged a little bit. Habilitative care, of course, is one that we could talk about. But we'll come back to that. Let me say just a couple of things about the commercial marketplace. One is that we are sort of on a knife's edge with respect to that marketplace because of cost-sharing reduction subsidy issues. As many of you know, there is a piece of legislation that is now on hold before the DC Circuit called, it was called State versus Burwell, now called State versus, or now called House, I'm sorry, House versus Burwell, now called House versus Price, in which some members of the House of Representatives challenged the provision of cost-sharing subsidies for low-income people in the commercial marketplace. District Court judge agreed that although that subsidy was included in the statute, it had never been the subject of an appropriation, and therefore it was unlawful for the administration to provide those subsidies. If you try to follow this tiny aspect through the whatever medium you consume to keep up with this stuff, you know that there has been a lot of worry that the new administration would simply withdraw the appeal, thereby ending the cost-sharing subsidy, which would make it very difficult for insurance companies. Ironically, it is the insurance companies who would be harmed by that, because the statute would still require insurance companies to provide cost-sharing subsidies for low-income people, but no one would pay for it. So the money would have to come from somewhere. So that's something that's sort of been hanging over our heads, and that suggests sort of a broader theme with respect to the commercial marketplace. The Affordable Care Act was what I thought of as sort of the last gasp, or the last attempt to create a market-based uniform-ish coverage system for people in the United States. And it really does sort of cobble things together. Medicaid was going to cover up to here, Medicare would cover here, and then the commercial marketplace would cover here. And that middle part is extremely important, particularly for people without employment-based coverage. And there were bits and pieces and a lot of moving parts that tried to make that work. And the truth is that in certain respects, it doesn't work all that well, particularly because of the high cost sharing that people in the individual and small group market experience. And the last 8 years has seen little or no attempt to ameliorate those issues from the government side. And where we are now is, who knows, but we're sort of stepping back and saying, if we are going to continue with this public-private partnership where we have government covering low-income and people with disabilities and seniors, and the commercial marketplace covering everyone else, there has to be coordination and mechanisms to support the transition between people low enough income to be covered by Medicaid and people who need financial assistance to be covered in the commercial marketplace. So we're looking to see what comes out. Are we going from 3-to-1 spread for the lowest cost premium to 5-to-1 spread, so that people like most of us up here would be in a band that would be 5 times the lowest price? Perhaps pricing people out. Will a cost sharing reduction actually go away in 2020, if not before, as current laws suggest? I think that what we've seen from the implementation of health reform over the last 8 years is an attempt to use the different aspects that are peculiar to the American health finance and delivery system to pull together in bits and pieces enough to get most people covered. And I think that we can talk about the details, but the back and forth that occurs, if you can just kind of screen out the sound bites, the back and forth that is occurring now is mostly about whether we will continue to strive to keep the people in the commercial marketplace that need help to be in the commercial marketplace, either because they're low income or because they have pre-existing conditions, or whether we will allow that to be eroded and go back to a time when we had a much higher rate of uninsurance. And I think we'll come back to many of those issues.
Yes.
Thank you. John teed up sort of the before and after question. So there's 2 themes that I thought would be important to address that. The first is to talk about this notion of what we had before here in New Jersey. I think what you'd see is that in many respects, New Jersey was a first draft of the Affordable Health Care Act. In 1992, Governor Florio signed a series of reforms which deregulated hospital rates, created insurance market reforms in the individual and small employer markets. Why there? Well, that's it's the old saying, why do you rob the bank? Because that's where the money is. Well, that's where the uninsured come from. It's mostly people who work for small employers and individuals. And New Jersey also had a health subsidized program to help people purchase coverage called the Health Access Program. If you look at the elements of that, a lot of those elements then found their way into the Affordable Care Act many, many years later. So we had guarantee issuance of all individual health insurance products. We were only really a handful of states that provided for that, regardless of your health status or health condition or prior claims history. You couldn't be rated based on your health status or many factors that insurers traditionally had rated risk on. Guaranteed renewability of coverage, standardized-ish coverage in the market, minimum loss ratios to ensure that insurers were providing good value for your health care premium dollar. and a subsidized program to help people purchase coverage in the individual market. Some of those measures were successful, some were not successful. But when you look at the insurance market reforms of the Affordable Care Act and compare how states, what they needed to do to comply with the Affordable Care Act, ours was a relatively small step up compared to other states. I think that's important to recognize that in dismantling the Affordable Care Act or portions of it through the ACA or whatever you want to call it, I think similarly there would be a smaller step down here in terms of protections than you might see in many other states. I say that without really commenting on ACA, but I do think that there's a number of protections in New Jersey law which would not be lost in the event of a repeal of the Affordable Care Act. I think the other thing that is really important to remember based on our experience here in New Jersey is that the efforts under the Affordable Care Act to expand coverage and improve access and help people financially from avoiding bankruptcy, which is healthcare was one of the leading causes of bankruptcy, was federal funding. So our program in New Jersey in the early 90s, the Health Access Program, I think it ended up covering about 23,000 people. You know, we've got 9 million people in New Jersey. Relatively small. It ended up withering away and transferring it over to Medicaid, and there's probably a handful of folks still left there. But the problem with the program was that there was no state dedicated funding for that. It cost a lot of money, and the state was not able to, based on its resources, to be able to continue to fund that in a meaningful way. You know, you can look at the Affordable Care Act, whether you're a proponent or opponent, you know, looking at the good parts, bad parts, whatever. But I think it's undeniable that the thing that helped gain access for so many people that was so important was the federal subsidies. So under Medicaid, which is where most of the expansion occurred, you know, we're at least at 500,000 additional folks covered under the expansion program. I think as John said, we had 1.3 million people uninsured. It's a huge dent in the uninsured population as a result of expanding Medicaid. The smaller portion of expansion occurred in the individual market. So we were at about 150,000 covered lives in New Jersey, and we are fluctuating now in a year between probably 360 and 310,000 folks. So there's an increase of probably 200,000 or so there. So you know that's a big chunk of our population who is uninsured that has access to coverage now. Absent federal funding, those expansions just aren't possible. The state budgeting process requires the states to have balanced budgets. You know, we have huge unfunded pension and healthcare liabilities as a state. I think we're behind only Illinois. The crowding out of public access to public funding is very real, and it's only going to get worse. I think it's important to recognize, again, whether you're, you know, no matter what you feel about the Affordable Care Act, I think it's undeniable that it was hugely successful in allowing folks to get access to health care coverage. I would also close on one note, which was that when the Affordable Care Act was signed, you remember the vice president whispered in the president's ear. Anybody remember what he said? He said that, you know, this is a big effing deal, Mr. President. Well, I would argue that if ACA is signed, it would also be another big deal, as it is really a significant change, especially on the Medicaid side of the funding. I'm not sure if it's gotten so much attention. It gets focused on the individual market mechanism and the mandate. But to me, the really important piece of this is what Medicaid funding and what the program looks like, and it would be significantly altered under the House version of the bill.
Well, we're definitely going to explore Medicaid. Just there's so much here, right? I just want to stay just for a few minutes on the commercial market, because I love the way Professor Jacoby kind of visualized it, right? We have Medicare, government program, Medicaid, shared funding between the state of New Jersey and the federal government, another government program, if you want to call it that. And then you have everybody in between, which is the commercial market, which is you have small groups. Most of us get our insurance through an employer-sponsored plan. So that's a market within, a sub-market within that commercial market. And then, as you've heard, you have individuals who are also buying their own health care. So I just want to stay on that a little bit more. So we're referring to the act as the Affordable Care Act, but of course the official title is the Affordable Care and Patient Protection Act. So we know, and as we've just heard, there's some very important consumer protections. So just staying on sort of thematically with both affordability and consumer protections, just want to ask two questions about the commercial market. Individual market first. What's the state of the individual market in New Jersey? We know how many people are getting their insurance. Tell us a little bit more about the cost. Tell us a little bit more about the offset for the cost, and what kind of plans are they buying? And this is a question for the group. That's how I'm going to be proceeding throughout, just general questions. Anybody can jump in, and if not, I'll just call on somebody. So who wants to just, what's the state of the individual market? What are people buying, and how much are they paying?
Sure. So on the what are they buying piece, it's been mentioned here that the planned designs have been changing a little bit. You have to start with the understanding that individual markets traditionally are dysfunctional. And it's
That's dysfunctional?
dysfunctional.
Oh, okay.
People know their health status. So someone who is 64 with a history of cancer finds great value in health insurance coverage. Someone who's 22 and healthy and feels that they are, we're not going to get sick, is not going to buy coverage. So the mechanism that pulls people into the market is their own individual decision making, which skews the risk pool. It's been a problem since it started. The group markets are different. If you're an employer with 1,000 employees and you buy coverage for your employees, you're going to have some young, healthy folks, some older folks, folks with significant health conditions and challenges, and others. The risk pool is more diffused, and it's easier to socialize risk among that population. The individual market has always been challenged. You tried to mitigate that in the Affordable Care Act through subsidies and with what I would call a weak mandate provision. But it didn't really totally solve the affordability challenge in the individual market. Responding to that, carriers have looked at plan designs to try to drive efficiency. So what you've really seen the big change in some states, you have very, very narrow networks. New Jersey doesn't really allow narrow networks. They do allow tiered networks. So they're driving folks to facilities and physicians that are promising two things. One is a lower unit cost, a lower rate for their services. And secondly, they are promising to generally to partner with the plan on population health to try to drive efficiencies through keeping people well and rewarding those facilities if they do a good job of it. So the plan designs try to drive folks to not only your network, but really sort of a preferred tier of networks where there's lower cost sharing. The plan designs tend to have higher cost sharing in the individual market than you see elsewhere. I would note here again, New Jersey is an outlier in that the Department of Banking and Insurance has limitations that you don't really see in most states. It caps deductibles at $2,500. And for the bronze plans, it's actually $3,000 because you can't get to a bronze plan with a $2,500 deductible. You see it throughout the country deductibles of $4,000, $5,000, $6,000. So again, New Jersey has protections around cost sharing for drugs, for deductibles and so forth that you may not see elsewhere. But there's no question there is higher cost sharing than what you see you tend to see in group insurance. So that's the what people are buying piece. And I would say that what they are buying has changed. Joel talked about the basic and essential plan. Arguably, it was more basic than essential. But that plan design is gone. So people are buying comprehensive coverage, which has the 10 essential health benefits in the marketplace. New Jersey really provided that already. The only big change was pediatric dental and vision, which was not covered under in New Jersey contracts. That's been built in, and a couple other things. But people are buying, they tend to buy tiered products. They tend to buy products, I think all the products now are in-network only, so you can't buy a plan with out-of-network benefits in the individual market. But people are buying comprehensive coverage at much greater numbers. As I say, it was 150,000. 2/3 of those folks prior to reform were in basic and essential plans. Arguably, it was in a compromised market with, some would argue, a death spiral. The Affordable Care Act has brought it back into over 300,000.
So we've gone from a like incredibly difficult position with regard to individuals buying insurance, right? So is our individual market, would you describe it as being sustainable right now?
Well,
Joel?
I can render an opinion anyway.
Mm-hmm.
So part of the answer to that question can come from comparing ourselves to other states. So we still have some competition, at least two big players in the individual market vigorously competing. How many total are in?
5 in the market, and 2 in the marketplace.
Two in the marketplace, AmeriHealth and Horizon. Before the Obama health reform, Horizon had roughly 80% of that market. They now have more competition than they did. It started out with a lot of competition. It has narrowed like everywhere. Premium increases last year when the premiums were filed and it was widely publicized that the national average increase in the marketplaces was about 20–25%, somewhere in that range. New Jersey was, I think, 7% increase. And I think some of the reason why ours was not as bad is that as Ward said, we have, not available, we had a lot of the same rules beforehand. I think our actuaries are smarter than their actuaries, right? And so our premiums were not, they didn't miss the target as much beforehand, so they didn't have to adjust. So that's sort of one point of comparison. The other, if you want to think about moving forward, assuming we keep funding for cost-sharing reductions, and that's huge. I mean, that is the giant poison pill. If that goes away, the market will completely collapse, I think. Insurance companies will, one estimate was, have to increase premiums by 15–20% just to tread water. That, of course, would drive more healthy people out of the market. It would be, I think, an Armageddon scenario, which is why even the Trump administration, which is vehemently opposed to the Affordable Care Act, keeps those going for the time being.
I just want to clarify for the group. This is cost sharing between the commercial carriers. I mean, I think this sort of goes underreported, right? Underreported that it's a tough business to make it to remain profitable. We see in other states what they're calling in healthcare deserts, insurance carriers simply pulling out of the market, leaving the consumers at a lurch. But you're describing a situation where, in order to keep the carriers in the market and having a sustainable individual submarket, we're actually funneling, the ACA actually funnels multi-millions of dollars between the insurance carriers, depending on how much risk they're taking on. And I just want you to kind of describe that for the group, because I think this is one of the great underreported stories of the ACA.
Well, who knew how complicated it was?
Yeah, right. Who knew?
So the cost-sharing reductions help people who are above the Medicaid threshold, 138% of poverty, and up to 250% of the poverty line to pay those deductibles and cost sharing. The money goes to the insurance companies because they have the legal obligation to give the reduced deductibles and the lower copays. John, I think what you're referring to is there were sort of premium stabilization
the risk sharing,
programs,
yes.
Risk sharing, which there were 3 programs, 2 of which have gone away, one of which has been dramatically underfunded and really triggered the collapse of the startup co-op plans, Health Republic in New Jersey, and some of the other smaller carriers. Those mechanisms were really designed to keep the market stable and to help out the insurance companies who were largely making, especially in states that didn't have the kind of rules that we did, they were making wild guesses as to who would enroll. And some would get hit with higher risk than they projected, and the risk might not be distributed equally among insurance companies. So there were redistribution mechanisms, reinsurance, and risk corridors, and I don't think it's worth going into all the gory details. It really is gory. But needless to say, or maybe it's not needless, it's important to say that some of those have gone away because they were short-term, only for 3 years, and what remains is not working. I don't know if either of you or...
Well, I'm going to follow up with John, but if you just want to just complete that thought, and then we'll move on. I have a question for John.
It's why our smaller carriers have abandoned the market and why there are these deserts in some states. You may recall the co-op program, which were nonprofit plans that were kind of the political compromise to not getting the public option. They would operate in the public interest, and they would be governed by their insureds, and they'd be not-for-profit, and they had some federal loans, but they really depended on these cross-subsidies. Starting out in this market, being the Bergenstock-wearing socialists, they attracted all kinds of folks who were higher risk. And since the risk stabilization programs didn't work, that was the end of them.
All right. So the more we talk, the more sort of my anxiety is starting to go up, right? Because a little bit, and we're definitely going to be speaking about Medicaid, but maybe the last question on the commercial market, and this goes to John Jacoby. And I think I'm paraphrasing you when you describe this mechanism that Joel has just described as was it the last gasp of the commercial market? Is that how you described it? And if so, what did you mean by that?
Well, last gasp may have been inartful. What I think if I can think back that far, what I think I meant was that we in the United States we have a more market-oriented mixed system. Almost every country, maybe Great Britain is an outlier, but even in Great Britain, there's a mixed public and private system. In the United States, we have more of a private system. We rely more on the private system than we do in other nations. And if you'll take yourself back to 2009, when there was discussion about Medicare for all, single-payer systems, and so on, there was a decision, a political decision based, I think, on probably a fair reading of the people of the United States, that the population of the United States was unwilling to move dramatically towards a national health system, and therefore we needed to have the mixed system work, but work better since we had such a high number of uninsured people and so many other problems. Now, just parenthetically, there are a lot of countries, the Netherlands, Switzerland, there are a lot of countries that have mixed systems, not that dissimilar from ours in structure. What they have that we don't have is a way of knitting the different pieces of the system together so that people don't fall through the cracks. So what I thought of in 2010 was that we were trying to mimic Switzerland or the Netherlands to build a connective tissue between the commercial market and the public system, such that it was far less likely that 50 million or 45 million people would fall through the cracks and not have coverage. And I think it was worth a try. I think that it is something that, with diligent attention to the kinds of mind-numbing details that people up on this panel think about too much, that we could make it work. It is the politics make it difficult, but I do think that there are ways forward. So I guess that I think that there are interregnums in the policy discussion in the United States, sort of between the big political blow-ups, when health policy people like Joel and Thomas and so on are able to sort of talk to each other about what might work here, and without it being terribly political. And I do think that there are things that we could agree, no matter whether you're Republican or Democrat, if you're looking at the nuts and bolts, that would help the current system to cover more people in a way that reflected getting them true access to care and not just an insurance card. And that might add some efficiencies to the way we do things. If we can't have that discussion, then we are polarized and therefore return to a system where there are a large number of uninsured people, or we're pushed to a system of national health coverage, one way or the other, but neither of those can be accomplished without a lot of bloodshed. So I guess that's what I meant by.
Could I add to that?
Yes, absolutely.
So I agree with John. I almost always do, and when I don't, I know he's right and I'm wrong. But I would say that the deep divide here is not necessarily around the how to make the private market interdigitate better with the public programs and so on. I think that the deep divide is really more fundamental than that. It is, it has to do with income distributions and taxation and benefits for low-income folks. So the main thing, the top two things I think the American Health Care Act does, the House bill that just passed, is repeals most of the taxes that were highly progressive, which is most of the taxes in the Affordable Care Act, dramatically reducing tax liability for the top 10% of the population, and at the same time dramatically reduces benefits for the lowest income folks, especially in states that expanded Medicaid, does away with that. So it's a massive income redistribution that goes not just setting the clock back to before the ACA, when all those progressive taxes were imposed, but way before that, because it does dial back so much on federal spending for Medicaid, which will then, because we have to balance our budgets, cause the states to dial way back on Medicaid over a 10-year period. So, those are the big forces in play here, in my opinion.
Right. I have the luxury of agreeing with the panelists. So, but you're right. Medicare works, right? Medicare. I mean, you look at what works in this hybrid system. Like most people would say that Medicare has been one of the most successful programs in, at least in terms of distributing healthcare in the widest possible way. The most successful program we've had ever in America. And I think that was part of the tension, right? Because when you want to spread that benefit, I think that we know that there was, at the town hall meetings, there was, a tremendous amount of consternation about diluting Medicare because of this idea of a zero-sum game. So if I have to give something to you, or if you get something, it's going to come out of what I already have. So I agree that the fundamental drama and political battle is over redistribution of a resource, of a social resource, and that implies taxation and what we're calling subsidies. But Medicaid also works. And that is, one of the great stories of the Affordable Care Act is the fact that the states ultimately, per the Supreme Court, were allowed to choose whether to expand Medicaid. So, Tom, I'm wondering whether you can help us move into a more fuller discussion about Medicaid expansion, and maybe give us a little background as well.
Sure, absolutely. And gentlemen, you can jump in as needed. But I think there's so much in the Affordable Care Act that I know we're not going to be able to talk about everything.
We'll do our best.
I know, but I think Medicaid is like the big topic that we should focus on. But I just want to like also ping off of like, young people staying on parents' coverage until age 26, that's in there. Reducing the donut hole for Medicare beneficiaries' prescription costs, also in the ACA. So, I mean, we're not going to talk about all those things, but in terms of Medicaid expansion, I think that has been a really great success here in New Jersey. In terms of new people being eligible for a program, right? People that we call, right, childless adults who previously couldn't get access to the Medicaid program, now are able to enroll, which has been really, really a great success in terms of that. What else in my background? How am I supposed to transition us to this next discussion?
Well, so we have expanded Medicaid in New Jersey, so maybe you could just sort of give us a little summary of where the state of Medicaid in New Jersey, and then we'll sort of go down the line.
I actually think you might be better suited to do that.
I can try. So there are about 500,000 more people enrolled in Medicaid now than there were at the end of 2013 before the expansion. I think one other really fundamental point when we think about what might happen in the Senate, and this is true not just in New Jersey, but we have to keep in mind that Medicaid is about 30% of total state spending. And I think in spite of his lack of love for the Affordable Care Act, Governor Christie was persuaded to expand in part because of the budget. He also said it was good for people, to his credit.
And that's 100% picked up by the federal government at this point?
Well, originally it was the expansion population was 100%. As of 2020, it's 90%, and then it's under current law, it stays there. Under the AHCA, it goes away completely.
So this was a great windfall for the state of New Jersey.
It was a windfall at a time when balancing the state budget is extraordinarily difficult. It was a huge help for a variety of reasons, even more so in New Jersey than elsewhere. But if this large federal subsidy starts going down, which is the plan in the bill that just passed, there would be dramatic spillover to other programs.
So before we get there, so we have 500,000 folks in New Jersey who have health care under expanded Medicaid who did not otherwise have health care. Tell us a little bit about that population. Presumably, most of them are working, but were not. Their employers were not sponsoring a plan. Presumably, most, if not all, were unable to afford a plan on their own. So, tell us a little bit about these 500,000 people who are now covered.
Well, they're all below 138% of the poverty level. So. That means that, many of them are employed. In fact, the labor force participation rate among Medicaid eligibles is higher than the population as a whole. These are people who are working, many of them 2 and 3 jobs. But they're not in positions where they get offered coverage either because they're part-time in several places or because they work for low-wage firms that are small and aren't required to offer under the Affordable Care Act.
I know we have a very sophisticated group here, but and but I just want to make the point that the folks who are getting covered under expanded Medicaid, by and large, are tremendous contributors to the state's economy.
Right.
Is that a fair statement?
Sure, yes. There is an irony in the bill that just passed, which allows states to impose work requirements with certain exceptions that would overlay a tremendous administrative burden to prove work and so forth on a population that's more likely to be working than others.
A younger population?
The expansion population's under 65, and I haven't seen the age distributions, but they are, the average spending on the expansion population is a little bit lower than it is for the rest of Medicaid, age adjusted. So they tend not to be quite as sick, although I think it's important to note that it's an extraordinarily heterogeneous population.
Right. I have seen some utilization numbers where that expanded population tends to access primary care much more than the general population, therefore stay out of the hospital, and that probably is a very good thing for the cost and service delivery generally. Is that?
Their health, yeah.
Yep.
You know, it does include folks, for example, who were never on Medicaid because they don't have dependent children but may be homeless and are frequent users of emergency rooms and have substance use and mental health disorders. And most of those folks were on general assistance or nothing at all before the expansion. And that led New Jersey and other states to look at using Medicaid, and they now have an application pending that would allow them to use Medicaid to pay for housing support services, sort of probably will be talked about in one of the breakouts later. It's not bricks and mortar or rent, but it's the support services to help people get and keep stable housing. There is evidence, pretty good evidence, that doing so actually reduces their health care costs. But if the expansion goes away, most of those people will be without coverage again, and there'll be no more supportive housing program in Medicaid. So it really is a game changer for a lot of folks.
Well, I think
As a healthcare, I think importantly, as well as the healthcare providers, the Affordable Care Act dials down the subsidies for charity care as coverage goes up. And the hospitals are major, they will complain with some legitimacy that Medicaid rates are too low, but getting paid something is a whole lot better than getting paid nothing or getting cents on the dollar under the charity care program. So this has been enormously helpful to our provider community as well.
Can I just touch
go
upon that
ahead.
if I
Yeah,
could,
no,
too?
I was gonna
The
ask you.
state publishes information about the dollars spent with the expansion population. So there's the first quarter of 2016 numbers I had pulled. And so for the first half of 2016, about 533,000 people were covered under the expansion population, and the state spend on that was $1.3 billion. So to the point of, like, you know, folks have a card, do they have access and are using services? I think the answer is yes. I mean, the accessing of services, and to your point, Joel, about the provider community, I mean, just to break this down, inpatient and outpatient care was about $700 million in a 6-month period for this group. So you think about this to no pay versus some pay. Medicaid covers 1 in 5 New Jerseyans. It tends to be a lower payer, but compared to no pay, I mean, that was a huge and significant change for the hospital community and the physician community itself. Doctor and professional services, $294 million in a 6-month period, and the pharmacy spend was $310 million. So, and I just, one point on that too is if you look at the Medicaid dollar and how it's spent, we just went through this exercise and looked at the state's numbers from 2011, the pharmaceutical spend was about 11% of the Medicaid dollar. It's now 22%. So there's a significant shift in the cost and relative, and well, as I said, cost and where our Medicaid dollars are being spent. Some of that's probably, good spend because you're keeping people out of hospitals, but clearly some of it is the cost of the rising cost of pharmaceuticals, it has a significant impact on the state budget.
I just want to continue just a little more on this, on the economic argument here, because what we're hearing at the federal level on the proposals and counter proposals on Medicaid, particularly expanded Medicaid, it's being framed in some ways as a welfare program, right? Like, who's deserving, who's not deserving? Should we drug test before people get health care? Should we require them to work? And, so I want to develop this because we're not talking about welfare here, right? We're talking about a program that, as you've just heard, had these multiple benefits and payoffs for the state of New Jersey, right? I mean, what's more beneficial than ensuring that workers who are contributing to the economy have health care so that they are productive and they're maintaining their productivity? I mean, that's a great net positive for the state. And then we have this other irony, if you want to call it that, charity care, right? I mean, we have a state law and a federal law where you can't be denied health care. If you walk into an emergency room, you have to be treated. That's federal and state law. And that is the most expensive treatment in the United States, is the treatment that you would receive in an emergency room. It's a huge infrastructure that has to be paid. It's astronomical, the cost of the emergency room treatment. So the whole idea of having health care is to keep people out of the emergency rooms. And as Ward said, okay, so doctors are going to be paid less, but it's better than being paid nothing, and then squeezing the the people who are paying for the plans a tax to pay for what we call charity care. So there's so many multiple benefits economically that I think it gets lost in the political rhetoric. And thankfully, we have this panel to help elucidate that a little bit.
John, could I throw in one more
Absolutely.
economic issue
Sure,
that I don't
sure.
think gets enough play, the financial benefit to the state of New Jersey that might be of particular salience to the people in this room. As many or most of you are aware, a lot of the payment for services for people with behavioral health needs and people with developmental disabilities is transitioning, has been transitioning for several years and is projected to transition in the future from state-only funds to Medicaid funds, for the obvious reason that the Medicaid funds come with a federal share. That shift, disruptive though it is, and I know that the way the shift is occurring has caused dislocations that are serious, and I don't want to minimize those. But that shift has allowed the state to draw down federal funds to pay for services that previously hadn't been paid for, and largely through the fact that there's an expansion population now, people re-entering society from incarceration, people who are single and not otherwise categorically eligible for Medicaid, now eligible under the expansion population, can get Medicaid to get access to care for behavioral health issues and physical health issues. Those are very important things for patients and important things for the state financially, so that if the benefits of that federal drawdown for the expansion population were to be seriously impaired, and I would suggest that under the current language that I'm seeing, and who knows how it will end up, that there's a real risk of at least a serious impairment of the coverage for that population. then the state will find itself in a situation where the system that it was relying on and projecting as providing a lion's share of the funding for care for these vulnerable populations will be less available. And the pension overhang and all that makes it difficult for the state to step up and restore state funding. So I think that I just wanted to point out first that there's an economic benefit to the state that sometimes doesn't get enough recognition from the Medicaid expansion for people with behavioral health and developmental disability needs, but also that having the coverage of that population threatened should be concerning for people in this room who are thinking about how likely it is that the state will step back in and restore state funds if federal funds dry up.
Tom, at your level, are you seeing is there a discussion on and data being collected on the economic impact, positive economic impact for extending or continuing Medicaid?
So in terms of Medicaid, so one thing I wanted to say when you guys were talking was also, like Medicaid, there are, each state's program is different, right? And so I think that's something to remember. The funding is expansion is one big topic, but in terms of how Medicaid is delivered, states have a lot of leeway in how to deliver that program, largely through waiver programs. So I think probably some of you are reading things about, the Healthy Indiana plan right now. But that doesn't mean that New Jersey has to have the Healthy Indiana plan, right? Each state gets to determine a large chunk of, so it's really about the funding, I think is what it comes back to, is if expansion is different, if there is no more expansion, how does it operate? And so I'm not really aware of any level of discussion within the administration right now. That's not my pay raise. But I think that it's obviously something that is in the room. I'm sure you're all thinking it. I know you all think about it a lot, and you probably have more leeway in saying things than I do. So I might kick it back.
Oh, you're among friends.
I know.
But the basic question though, is there a focus on developing and measuring the economic impact? Because it seems to me that when the politics are all, shorn away and all the emotionalism is played out, and we know how partisan things are. At the end of the day, there could be a rational choice that needs to be made. What's in it for us? And it turns out that Medicaid expansion, there's a lot in it for the state, and it's just not a giving a benefit to someone. It's a collective benefit for the whole economy. And I'm just wondering whether you hear that or see that at your level.
Well, there are some private groups that certainly look at these things, sometimes in specific states, groups like the Urban Institute that looks more broadly across the country. The first thing I'd look for is the next CBO report, which is due out
which is missing
shortly.
Which we don't have yet.
And
you want to just explain that to the group of what
the Congressional Budget Office is the official scorekeeper for Congress, nonpartisan group of folks who really their job is to project the impact of any proposed or actual legislation on the federal budget. They go beyond that, so they will project, for example, the impact on the number of people covered. And the CBO report on the first version of the AHCA had, over the course of, they look at 10-year windows, over the course of that window there'd be about 24 million more uninsured. It had a little bit of a deficit reduction benefit because of really paying less for Medicaid mostly and subsidies in the marketplaces. So we need to be looking forward to that, and I think that as we look toward what the Senate might do, I think that will loom large in the debate.
So I'm going to ask the group to comment to the extent possible on the bill that passed on Thursday, and perhaps some commentary on what we think the Senate might do. But before we, I have some Q&A worked into the discussion. I don't know if we're set up for that or not, but maybe we'll just play that by ear. But in any event, before we get into the legislation, I want to talk about behavioral health care. I know that there are many advocates in the audience this morning, and they spend a lot of their time in that area. I guess Professor Jacoby, you might want to tell us a little bit about, and then we'll ask some specific questions of the group. Tell us how behavioral health care what part behavioral health care plays in the Affordable Care Act, and then we'll move on to maybe some service delivery questions as well.
Okay, first I'd like to pick up on what Thomas, I'm sure, was not hinting at. But I do think that it is true that New Jersey is not Indiana. Historically, New Jersey has had has forged a different path when it comes to the structure of its healthcare delivery and finance system than many other states. I think that when I read about what might happen with the AHCA, I am constantly thinking about one aspect of what Thomas said, which is that policy development in New Jersey policy development becomes even more important than it was before. We had, I'm overstating this, but Medicaid for the last 52 years was arguably a system with very strong federal structure that allowed for Medicaid to persist. It's a counter-cyclical program when it's most needed when states have the least money, and strong federal oversight and strong federal funding was so important to maintaining the integrity of the Medicaid system. To the extent that we move away from that, it is more important than ever that we think about how New Jersey should develop its system. There are a lot of innovative things being done in and out of government with respect to Medicaid. Some of them have to do with determinants of health, like trying to weave housing and other issues into the Medicaid program or associated with the Medicaid program. Those are incredibly important. Those are great, whatever the financial impact is. Those are great for members of the Medicaid risk pool. They're great for patients to have someone who cares that they're getting sick because they're homeless and therefore tries to make sure that their homelessness is addressed. Okay, so with respect to how behavioral health plays into this debate, as I suggested earlier, the ACA, I think, both by working the essential health benefits requirement into the alternative benefits program that applies to the expansion population, and by creating a number of pilots that help to try out integrated health delivery systems, that the ACA provided a bunch of tools that I feel like we're just starting to get traction, and may still. So the ACA allowed us to rethink, to a certain extent, how the finance system and care delivery for not just people with mental health and substance use disorder issues, but also people with developmental disabilities, how their care will be delivered. As everybody in this room knows, I'm sure, the health of people with severe and persistent mental illness is throughout the country very poor. There's a 25-year shortfall in life expectancy for people with severe and persistent mental illness compared with the background population. And the reason for that is not their mental illness, it's because they're not getting appropriate physical health care. And the reason for that is the legacy of our healthcare finance and delivery system that fails to treat the whole person, but rather segments the person's care into mental health, physical health, and substance use disorder. And many people in New Jersey and elsewhere, clinicians have been working over the last 15 years or so to develop really promising systems to integrate care for people with severe and persistent mental illness and for people with mild to moderate mental illness who are not getting appropriate mental health care, and for people with substance use disorder and developmental disabilities. Those systems are clinically promising. There's a lot of data on the benefit to the patients of those systems. There are legal problems with implementing those, and we at Seton Hall have done some work on that. The main ones have to do with financing. It's fine to have a clinical model that would provide appropriate care, but if the money doesn't follow the clinical advances, then the clinical advances are not going to be implemented. So it's very important for, particularly Medicaid, to make sure that they're funding those promising programs. And I believe that there's a will in Medicaid to do that. It could be happening more quickly, but I believe there's a will to do that. So there's financing. There are privacy issues that are maddening because a lot of people overread HIPAA and privacy laws and believe that they create barriers to health integration where they ought not. There are some areas, particularly with substance use disorder, that are trickier. And the last thing is licensure. That it's an incredibly pedestrian issue, but an incredibly important one because not just in New Jersey, and I dare say every state, there are problems with legacy licensure rules that inhibit healthcare providers from creating the integrated delivery systems that everybody thinks they should be creating. And we are now working with both the Department of Health and Department of Human Services, and I've got my fingers crossed. I will show you that they will carry through on what I believe to be their desire to fix those licensure standards to make it easier for those clinical settings to come together to provide care for people. So Medicaid is a finance entity. It's a financing system. If clinical care isn't available to provide services, then the financing won't do the job we want it to do. And if the financing is fragmented as a clinical care system used to be, then the clinical care systems won't be able to get up and running.
I'm going to go to Ward and then to Joel. So Ward, it seems to me that the plans, the health plans, have a vital interest in coordination, the healthcare, behavioral healthcare coordination and delivery. If they want to see this, code cracked, if you will. Maybe you can talk about what the plan, what the perspective of the plans are in all of this.
Yeah, I would say this is one of the clear frustrations that the health plan community has on the Medicaid side, that behavioral health care services are carved out of the Medicaid contract. So while most folks have 95% or 97% or something have managed care services or services provided by a managed care organization, the one big piece that's carved out is behavioral health. I would say I remember the first lunch I went to when I took my job 10, 11 years ago was the medical directors, and it was the frustration they had was that trying to provide care to folks, and so many of the folks in the Medicaid community have dual diagnosis with behavioral health issues and health issues. And their role is to, sort of stratify risk, to manage care, to find resources for folks. And it was so challenging because it's sort of a, kind of a black box on the behavioral health side. It's very hard to treat those folks. So I know that they are supportive. The transitions are really important in all this. The population for long-term services and supports was transitioned into managed care a few years ago, and you really need a glide path to be able to transition these folks appropriately.
I mean, I guess for the plans, the cost is probably one of the major issues, right?
Yeah, and they're given a task by the state produce good health outcomes for the community of the folks that they're covering. And this population is extraordinarily challenging just because of the bifurcated system that we have here. So they are supportive of that change.
Joel?
So first, if you're, I think what both of my colleagues are saying is there's just some tremendous work in progress going on to better integrate behavioral health services with physical health care. And I agree, it's too slow and frustrating, and they're hard, vexing problems. If you are interested in the health information, privacy questions, or these legal questions, I'll just give a quick shout out. There's a couple of reports on the Seton Hall Law website that are outstanding that go into these issues, and recommendations authored by John and his colleague Tara Ragone. So I commend those to you. Also, I'll shout out one of our reports too, which is to put a fine point on some of this. At the request of the governor, we examine the expenses and the health profile of the most expensive people in the Medicaid program, and of folks who are in the top 1% cost spending for the Medicaid program. 80% have at least one behavioral health diagnosis of some kind or another. About a third have a severe and disabling mental health problem. So this is no trivial problem, and it's costing more money than it should, and people are not getting the care they need. The other thing I wanted to mention, and I think that Medicaid is sort of the big issue here, because so many folks on Medicaid have multiple diagnoses, behavioral and physical health problems. But it's a big issue in the private market as well, and one that I think is at risk. We had a Mental Health Parity Act before, federal, state, and so forth, which said if you, employer or insurer, covers some mental health benefits, it has to be on the same terms as physical health services. But there was nothing before the Affordable Care Act that required those benefits to be in the benefit package. And the ACA has the 10 essential health benefits, and behavioral health is one category. Now, the proposed the bill that just passed would give the states pretty easy access to just waiving those. And so in the private market as well as in the Medicaid program, I think just the fundamental benefits are at risk, and all the progress we're talking about, better integrating, better financing, better delivery systems, overcoming, protecting privacy appropriately without having those things be barriers, that work is not going to help much if the benefits aren't covered.
So I want to talk a little bit about outcomes too. So we've had a good discussion about accessibility. If you think about the promise of the Affordable Care Act, obviously it's one of the major objectives of the law was to make healthcare more accessible. So we've been talking about that both in the commercial side, but also on expanded Medicaid. We've talked somewhat about affordability. The ACA has major challenges. Clearly, we may be able to agree that it's achieved wonderful results, again, with making healthcare more accessible. Making healthcare more affordable is, quite frankly, a work in progress, and we've talked about how the mass millions of dollars, if not billions of dollars, offset costs, not only for the consumer, but between the private carriers as well. So that's a very complex kind of back end there. Equally complex, it seems to me, are the outcomes, because that was the other great promise of the law, was to make healthcare a little more affordable, certainly more accessible, but get better outcomes. Quality is a big issue. I'd like to talk about that a little bit. But also how providers are paid and what they get paid for. So why don't we start with Medicaid? And maybe, Tom, you can comment on what's happening on the back end with regard to service delivery. We've heard about accountable care organizations. Those types of, I would call, almost pilot projects to deliver healthcare more efficiently, but just as importantly, to get better outcomes.
Absolutely. And so I think Medicare is relevant to this conversation because Medicare is the national program, right? And so things that get set in Medicare can have influences on both the private side as well as the Medicaid side. As John mentioned, this whole new world of outcomes and performance measures and paying for performance is still the direction that our healthcare system is going towards. And so we want to know that the money that's invested into healthcare does lead to improved health outcomes. And I'm so glad that the social determinants of health have already been put into this conversation, because that's a really major draw. We know that people's health is influenced by many things that we don't call health: employment, housing, all sorts of things, the environment, right? There's a lot of things that are non-traditional health arenas that actually have really big impacts on people's individual health outcomes. And so I mentioned kind of in my introduction that we have a newly formed Office of Minority Health within the Centers for Medicare and Medicaid Services. And one of their major things that they're working on right now is building an organizational response to health disparities. And so the format that we're looking at is first we need the data, right? We can't say that there's health disparities or poor outcomes if we don't have the data that shows us that story. But just collecting the data isn't enough, and we need to be collecting the right data to answer the questions that we want to see answered. So we need to analyze that data, and based upon that analysis, we need to come up with interventions that work. And so things like the accountable care organizations on the Medicaid side, they're also on the Medicare side, are thinking of ways that we can better coordinate people's care and link them to different services, behavioral health being a major one that we've already talked about, as people not being able to access or people not having that need met necessarily. So I think that you're gonna see more and more of that, and so we've been focused on legislation related to increasing access, but there's been legislation since then, the macro law, which is really focused on bringing Medicare much more in alignment with quality. So is that a springboard for a conversation?
I think so.
Okay.
I'm taking my notes here. Incentives for better outcomes, I think, might be a good thread before we get to the Q&A, and that is just a general question for the group. Where are we, Joel, where are we with incentives both to hospitals and providers to get better outcomes?
So the Affordable Care Act has about 10 different major sections, 10 titles. And when we talk about the American Health Care Act, I think it touches 3 of those. The Medicaid, the exchanges, and the revenue.
Oh, that's interesting.
But it doesn't really touch the stuff Tom's talking about. Right. And MACRA passed in 2015 with overwhelming bipartisan support. So we are on a path toward a system that's leaving fee-for-service with its incentives for doing more, regardless of the benefit, to a system where it's basically pay for performance. And under the Affordable Care Act, there are some really early success stories. There's still sort of wild experimentation going on out there, and things that are not going to pan out. Frankly, the ACA kind of threw the spaghetti at the wall, if you will, and some strands are sticking and some are not.
Yeah, well, it sort of begs the question, though, paying for, we're talking about delivery of health care. It seems to me that outcomes are incredibly important. Absolutely. And it's counterintuitive to, at least to me, where I have to incent you to, I have to pay you more to get a better outcome.
Not
What-
necessarily.
Okay,
Sometimes you
well,
pay
I'm
less.
going to counterpoint. I want you to explore that a little bit, because to the layperson, it's, okay, so what am I paying you in the first instance? I mean, why aren't I paying you for the best outcome I possibly can? Why do you need an incentive to get a better outcome? Systemic question.
Incentives matter, right? Incentives matter. I work with too many economists to not believe that.
I'm shocked.
And
Healthcare
so-
delivery
and the
is a
incentives
financial
have been
matter?
skewed toward higher volumes and higher prices. And we're trying to move away from that as a system. I'll give you one example that is not paying more to do the right thing. It's paying less when you do the wrong thing.
Okay.
Which is one of the big success stories here, and that's the readmission reduction program, part of the ACA, which has been phased in. And hospitals that treat patients, Medicare patients with conditions that have high readmission rates, things like heart failure, 25% of those folks can come back to the hospital within a month for a variety of reasons, mainly that their care, they didn't transition out of the hospital with a plan that they could follow. So hospitals now get dinged very substantially financially if their readmission rates are too high. And the readmission rates have come down dramatically, something like 15%, something in that. And that's a simple incentive. I mean, it's complicated as hell, pardon me, but it is one of the simplest incentives that we've imposed, and it works well. Hospital-acquired infections, another area with big successes. Whether the big complicated things like ACOs really do lead to long-term savings is a big fat open question, but there's a huge amount of experimentation going on. And I think the train has left the station, and we are moving toward a more value-based payment system in every sector, led by Medicare and followed by others.
We'll explore that. This gets my blood boiling a little bit. Paying hospitals not to make mistakes. I mean, I'm not.
The challenge in all this, though, is just to speak at a, I think, accurate but superficial level, is that it's easy to pay for services. It's hard to pay for quality because you have to define what quality is, what efficiency is. And so that's the big challenge as we move for this. The Affordable Care Act's subsidies and the payment for Medicaid are masking the cost to the consumer, but those provisions don't really change. The great hope in the Affordable Care Act, and even without the Affordable Care Act, is this transition from a fee-for-service model to a pay-for-value model. And I think arguably we have taken baby steps. We're probably in the shallow end of the pool, and there's a sense that we need to get into deeper waters here. So if you look at the relationship between payers and hospitals and large provider systems, 10 years ago they were at either side of a table yelling at each other over rates, and that was the sum total of their discussion. It's completely changed now, where there is more of a partnership model as hospitals are incented through some of these programs that Joel talked about to keep people out of inappropriate readmissions and so forth. They're talking about how do we align our interests so that we help you. And part of the financing of this has to drive this, so that if the hospital does the right thing, that the payers are rewarding that for keeping them essentially out of their hospital and giving them less business. But so those models are evolving. There tend to be more at this point quality driven, pay for performance. I think that there's an understanding that there will be an evolution towards hospitals and providers bearing risk. And there'll have to be protections against that to make sure that they're doing so appropriately. But that shift is really a lot of what the hope is to try to bend the cost curve, because just providing subsidies, we want to make sure that we're throwing good money after good quality and efficient care. We can't just keep paying, tax dollars to mask the true costs.
Yeah.
Two quick things. First of all, I completely agree that the data are going to be really important here. I have been involved in some of the wacky attempts to experiment. And I'd sure like to know whether it's done any good or not. And Joel's going to tell me. Joel's charged with telling me. So that's one thing. I really think that the data are going to be important because we are trying a lot of things. The second thing is that the spaghetti that was thrown against the wall, I don't know how far I can take this, but comes from the trattoria of the private market. The value-based payment existed before the ACA. The ACA adopted a lot of the models that private insurers and health systems have been working on. And regardless of what happens in Washington, that movement will continue. Value-based payment is the future. There's no question about it. What I advocate for when I talk about value-based payment is to open the lens a little bit. It's one thing to say that we should be looking at, with hospital readmissions, for example, about whether the treatment plan was appropriate, whether someone made connection with their primary care physician in an appropriate time, and so on. I think that what we will find over time, and it'll be hard to tease out the value here, but we'll find over time is that what we also have to look at is whether that person goes back to a safe house, or whether that person has access to nutritious food, or whether that person has an employment opportunity or an opportunity for exercise. So I like to urge people to think about healthcare as different from medical care. Healthcare is broader. Healthcare includes addressing the social determinants of health so that people can stay healthy. Most of, I don't like to tell doctors this, but most of what keeps us healthy, most of what defines our health status is not the health care we get. It is other things. It's the quality of our housing. It's the quality of our environment. It's the quality of the food that we eat, how much exercise we get. So if we can open the lens a little bit and charge the people we give the money to provide care for populations with the responsibility to think about their wellness, then they may see it as part of the value proposition for them to deal with the social determinants of health, as well as connecting people to subspecialty care.
Yeah, the other half of the coin is the consumer. So one of the theories underlying the Republican bill, right, is that in a market, more or less a free market, people will make rational economic decisions in their own interest. It seems to me that as a consumer, I'll speak for myself, I'm not particularly a rational consumer of healthcare. There are issues as to delivery, but there's also, I don't even know what I'm buying, right? The employer, well, I am the employer, but the employer, buys the plan or self-insures, negotiates the fees, gives it to the, offers it to the employee, kind of as a take it or leave it. So, that whole purchasing of the plan somebody else is doing. I'm paying, maybe $10 at a pocket at the point of service, so I don't really have a good idea of what I'm buying. And in terms of my own evaluation of quality and outcome, it's really subjective. So I don't know if there's a market solution here based on the consumer making rational choices. Anyone would like to weigh in on that? And because it seems to me that so much of the Republican plan is based on this rational economic choice theory. What's happening? What has the ACA done with regard to consumer education?
Well, I do think there was efforts in the Affordable Care Act to address the concerns you're talking about, John. So you think about food labeling now, you look at the food and there's a little, the code that tells you, what vitamin A, vitamin C, and so forth. So in the exchange process where you arguably need the most coaching, they tried to provide, well, there was some level of standardization, but there was also an education. The portal was to help educate the consumer decision-making process. And having worked at the state level, trying to educate consumers, with a small budget, you do a buyer's guide and you publish rates and so forth. The portal, I thought healthcare.gov, while it had a rocky start, I was just on it yesterday to look at some prices to get a sense of the market. But I do think that it helps. An insurance contract is always going to be at least 100 pages long because it's complicated. But I thought they did a good job at standardizing the format to help educate the consumer in a useful fashion. And so I do think that there's an increased movement towards consumerism in healthcare that's good to help educate folks, to standardize presentation, all important components. We've got a long way to go, but
Yeah, well, maybe that's one of the takeaways, because as we're suggesting is that the state of New Jersey is going to be, if not on its own, certainly going to be thinking significantly about what kind of plan and we're going to have. So perhaps one of the takeaways might be a role for consumer education, because part of the ACA was to provide grants for navigators. In fact, CHLP did some tremendous work as a navigator, and others in the room. So maybe that's something that we want to, or we can pursue in terms of putting together what the state will do going forward, is consumer education.
Just a couple of points. I agree with you that the Navigator programs, the website and so forth, have made tremendous contribution, have come into their own, ironically, as we're maybe going to shut it down. But also a point I want to make is that when we compare ourselves internationally to other developed countries on a per capita basis, Americans have more out-of-pocket exposure than almost anyone. So when you hear the argument that consumers need more financial skin in the game in order to be smarter consumers, things like health savings accounts and dramatically expanding those, I would be very, very skeptical. The evidence is that people do cut back on care when they have to pay more out of pocket, but they don't necessarily cut back on the inefficient or unnecessary stuff. And they do cut back on things that they do need. So I'm skeptical of that. Final point, there's actually some pretty good evidence building that if you structure incentives right, that people will do the right thing. So that if you make the healthy choice, the easy choice, or the most rewarding choice, people will quit smoking. They will deal with their diet. Those things are hard to change, and well-structured incentives work. And I would argue most employer incentive programs are not well-structured to get folks there.
I agree. I mean, that's another panel discussion, but we can also charge more for smokers, by the way. But it's a difficult conversation to have.
As
Yeah,
well.
right.
The ACA permits it, and it didn't work well, but that's another conversation.
Another conversation. So that leads us in. We have about 6 or 7 minutes left.
Can I just say one more?
Absolutely,
Sorry.
absolutely.
I'm worried that we'll miss this, and I know that looking around, there are a lot of people here who represent individual consumers, and I just wanted to point out a couple of the changes that are teed up that are in the AHCA that you should be aware of. That, of course, it's not the law yet, beer party or no, it's not the law yet. So there are a couple of things. Presumptive eligibility will be gone in 2020. You should be aware of that. Retroactive eligibility gone in October 2017 if the bill is signed.
Just clarify that. Eligibility for?
Medicaid. This is all Medicaid.
Okay.
I'm sorry.
All right.
I'm sorry. So presumptive eligibility, hospitals have the power under current law to find someone presumptively eligible for Medicaid, and that person's care can then be paid for by the Medicaid system. That is scheduled to go away in 2020. Retroactive eligibility, which allows someone to have their bills paid by Medicaid, to look back up to 3 months to the time of application, is going to be gone in October of 2017, according to the bill as it exists now. 6-month recertifications apparently will be required. And last time I was in state government, that was something that everybody hated. Everybody hated it. It was, I say this advisedly, it was the stupidest thing because it simply, it caught very few people who are no longer eligible because of reporting requirements, and it forced a lot of people off because they didn't recertify, but those are going to be mandatory again. Why? You can make your own guess as well as I can. The optional work requirement has been described. So there are going to be, you have to keep your eye on what these changes are. As I'm sure many of you know, I think the best source for that sort of information is Kaiser Family Foundation, kff.org. They keep very good track of what the changes in Medicaid eligibility and benefits are. So I just want to get that out. Sorry.
No, I mean, that's was absolutely perfect because that's where we were, that's how we were going to conclude. I would just add, though, just a couple of other points. And we think that the Senate will fix things, right? I mean, that's the presumption even from the Republicans who voted for the bill, knowing full well that there are going to be certain fixes. So 2 areas, and then we'll conclude. What do we think will happen with pre-existing conditions? And do we think that older workers or older persons will be gouged for their health care? My characterization. So
Older people will pay more.
older people will pay more. All right.
People
3 to 1, 5 to 1, because there's,
And also the way the subsidies are restructured will cause them to pay more. In terms of pre-existing conditions, it opens the door, and I think New Jersey will be better than most, but it certainly opens the door. People will have to have access to something, but in so many cases, it will be something that's so financially out of reach that it'll be nothing. So it will hurt people with pre-existing conditions if enacted as currently framed.
well, do you think there's going to be any traction to these risk pools that are being discussed, these high-risk pools?
History suggests no.
Because our experience in New Jersey with high-risk pools has not been that good.
We haven't really had one. I think the
Had
national.
one for about, what, 6 months or a year or something?
Oh,
or?
you talk about the temporary high-risk
Yeah,
pool that
yeah.
was under the ACA. Yeah, that we burned through that money really fast.
All right, so just,
Another
you know,
story.
high-risk pool is putting, it's what it sounds like, right? We're putting people with a high experience, high risk into a separate market.
We'll help young, healthy people by segregating out older and sicker people. I would argue that the federal bill, as it's moving forward, doesn't have nearly the money, I'm not the only one arguing that, to make the premiums in those high-risk pools affordable.
That was the challenge prior to the ACA. The states that did have high-risk pools had funding challenges. So they had certain levers to push and pull. One is to deny entry to new folks, to limit benefits, have dollar caps and so forth. They tried to manage the money that they had, but I think there was a strong argument that at least at the state level prior to the ACA, the funding wasn't adequate to address the needs.
The politics are such that
Wait, get closer to the mic.
Politics are such that achieving sustainable and adequate funding for high-risk pools is just not going to happen.
Well, we are, a remarkable discussion. We're pushing 11:30. If you can just welcome with a round of applause and a thank you for our panelists. I'm proud to be giving you this on time. Back to Hal Garwin.
Thanks, John. Thomas, Joel, Mr. Professor Jacoby, Board, I want to thank you. You guys did a wonderful job, I think, talking about a very complicated and difficult topic that, as we all know, has been ever-changing and still stands probably for some more changes, but poses all kinds of problems for variety of people going forward, depending on what the Senate does, and then whatever changes in the House-Senate conference comes about. But there's a lot of sensitivity, there's a lot of issues, there's a lot of danger coming ahead, both fiscally and substantively for people. So I thank you for a great discussion, I really do. Let me just go through a couple of housekeeping things, but I do have one comment, probably take the prerogative of having the microphone. John said a few things about healthcare and mentioned how there's more to healthcare than the provision of the actual medical treatment. There is. In fact, CMS, in all its wisdom, a little while ago, in talking about its determinations and what kinds of activities make up the well-being of an individual, and they added something